Welcome back to Oncology for the Inquisitive Mind, where we are continuing our extensive stage small cell lung cancer duology. We are going to we talked last week about limited stage small cell, but this week we're going to expand, we're going to extend our horizons perhaps and talk more about the more advanced and far more common extensive stage small cell lung cancer. I am enjoyed by my fellow member of this magnificent two that we have, Josh Hurwitz. Josh, how is Melbourne? Because if you listen to our last conversation, you'll know that I am much warmer than Josh now.
And you even have a tan now, Michael. You've only been there for less than a week.
I know. The melanin is strong in this one.
It's overcast. It's a little bit windy, but I get to look at gum trees while we're recording. So if this is as bad as life gets, seeing you in gum trees, I'm pretty good. So thank you for asking.
So yes, we're going to discuss a couple of very interesting studies focusing on extensive stage small cell lung cancer. We've gone through the background of small cell lung cancer sort of writ large last week. So if you have any questions or queries, listen to that episode. It's a good one. But the long and short of it is, in the immortal words of Yul Brynner, great actor, famous for the Magnificent Seven, don't smoke. Otherwise, this is what might be waiting for you at the end. Josh, on that particularly grim note, why don't you get started? You know, I've always thought of you as a bit of an oracle. Why don't you gaze into the future and talk to us about Delphi 304?
Yeah, that sounds great. Michael, I had a heart attack because I looked at my heading of my notes. I'm like, why do I say durvalumab again? I've obviously been tired when I'm writing this. Don't worry, I haven't spoken about durvalumab. It's just the random heading.
Josh is just on the payroll for durvalumab.
Oh, Matt, if I was on the payroll, I probably wouldn't be doing this. Let's be honest.
That's true. I like to think that my sunny disposition would have dragged you here anyway.
Yeah, 100%. That smile, ridiculously nice. There it goes again. We are getting onto YouTube. It's just taken some time. Let's talk about extensive stage small cell lung cancer. 5-year overall survival is less than 5%. That is really bad. Median overall survival with therapy, so the standard of care, which is chemotherapy plus an immunotherapy agent, atezolizumab is sort of what we've used, is about 12 and a bit months. The improvement with immunotherapy, and I don't have to have this in my notes, something like 2.6 months in OS. That is not a lot. The prognosis is poor in those where disease is resistant to platinum-based chemotherapy, but that's most people, I suspect. And the second line is topotecan, lurbinectedin, and amrubicin, which are approved in certain countries depending where you live and work and study, but it hasn't really improved outcomes versus topotecan. The median overall survival is about 7.5 to 9.3 months with notable hematological toxicities. Enter a new drug, and this is where it gets fascinating. Tarlatamab, which is another bispecific T-cell engager. And I feel in my oncology bones, Michael, that this is kind of that next line of post-immunotherapy agents.
Which bone is the oncology bone, Josh?
You usually make humorous because I'm so funny.
Good answer. Look, this is the gold standard, isn't it? When you've got a very difficult to treat cancer, you find that target that is not only a potential therapeutic target, but it is also very commonly expressed, which means the applicability of your drug is very high.
And there comes in the Delphi name, which is this particular T-cell engager targets the DLL3 delta-like ligand 3. On the cell surface of these small cell cancer cells, it is present in up to 96% of cells, which is insane. Really, really high.
Not exactly ROS1, which is about 3% of non-small cells, is it?
That's the thing. And, caveat here, PD-1, PD-L1 expression doesn't always correlate to response, and that could potentially also be the same with the DLL3. But the phase 2 trial was pretty promising. It showed an objective response rate of 40% and a median duration of response of 9.7 months and a median overall survival of 15.2 months. Not shabby for a phase 2 second-line trial with small cell lung cancer where the median overall survival is 12 months.
Pretty much on the dot.
On the dot, 100% on so many dots, Michael. So it's a randomized, controlled, phase 3 Delphi 304 study with a key inclusion criteria being you have to have small cell lung cancer progressed on one line of therapy, which should be chemotherapy and immunotherapy. And then you move on to a good ECOG status and you're randomized based on the prior PD-L1 exposure, chemotherapy free interval. What's that? Less than 90 days, more than 90 days, less than 180 days versus more than 180 days. And that comes into, I guess, responses. So people who've responded really short amounts of time are probably not going to do as well, irrespective of your drug. I don't think there's going to be, don't quote me on that in the trial, but usually what you see is people who burn through therapies will burn through second and third lines as well. They're then randomized 1-to-1 to tarlatamab, which is the name of this bispecific T-cell engager, versus chemotherapy. And topotecan was the most common, the lurbinectedin secondary, and then amrubicin was the third line. Tarlatamab, I don't know how to pronounce it.
Tarlatamab, if you're from Bristol.
That's it, Bristol. Tarlatamab is given on days 1, 8, and 15 of one cycle, and then Q2 weekly afterwards in a 28-day cycle. Demographics, about half had brain mets, about a third have liver mets, 71 had prior PD-L1 or PD-1 inhibitor therapy, and 44% were considered platinum-resistant disease. At data cutoff, the median duration of therapy was 4.2 months, up to 17, and 2.5 months in the chemotherapy arm, up to 14. So there's always going to be those responders, irrespective if you're chemo and irrespective if you're this new immunotherapy agent. So the median overall survival was 13.6 months in the tarlatamab. Have to clarify that was not reached, and 8.3 months in the chemo arm. And so the hazard ratio was 0.6, so 40% risk reduction of death. The overall survival for tarlatamab was 76% at 6 months and 53% at 12 months. And then subsequently, chemotherapy was 62 at 6 months and 37% at 2 months. So you're looking at least a 15 to nearly 20%. I'm 47, 16% difference at the 12-month mark. So still not bad. Do not laugh at my terrible maths.
I will laugh at your terrible maths and I will enjoy it.
Thank you. Thank you. When you're looking at the progression-free survival, probably wasn't that great. So it was 4.2 months in tarlatamab and 3.7 months in chemotherapy. And at the 12-month mark, it was sort of 20% versus 3%. The 12-month mark, you can kind of see that those that respond will continue to respond in tarlatamab, and those that are on chemotherapy, it's very few and far between. Objective response rate is also higher, so it's about 35% versus 20%. That's really it. And then if you look at the side effects, also really interesting, higher in the chemotherapy arm. When you look at all of them, and then if you look at the treatment-related adverse events, it's pretty similar and much higher effective grade 3 events in chemotherapy. So in the tarlatamab, like bispecific T-cell engagers, you're going to get neutropenia, lymphopenia, and you can't forget cytokine release syndrome, which is actually quite manageable in big centers. When you bring someone in, you can give them steroids, you can give them whatever your second-line agent. And discontinuation was double in the chemotherapy. So that's my summary, Michael. So I think we would love to see some more follow-up, but honestly, it's probably the most exciting second-line study I have seen in this little Back to Basics series in such a hard-to-treat cancer.
I often thought, because I like to draw parallels, second line small cell is in that same category as second line in biliary tract cancer or advanced urothelial or melanoma, where you have not a good, but a decent treatment option up front, and then just nothing that works in the second line at all. So I think that having this new targeted therapy is very, very exciting. And obviously, you mentioned greater follow-up. Absolutely. What I'm really looking forward to is the inevitable combination or integration, I should say, of tarlatamab into the first line. Based off these results, that's what's coming next.
Exactly. They're going to move it up unless there is some statistical error that rocks up on your doorstep. It's like, well, the second line treatment is so good. We are going for that first line combination or single agent or whatever it is they want to do. And it's relatively tolerable. So, Michael, quite an exciting time in the small cell world.
Yeah, no lose proposition, I'd say.
I think I've had one patient that I can say who 5 years after diagnosis is still alive. She was still coming in with immune-related adverse events 5 years down the track. So yeah, she survived and she did brilliantly, but also rough.
And at that point, you'd wonder if it was a ongoing immune effect rather than her second line therapy.
That's it. She wasn't on second line therapy.
Oh, it was just first line. Yeah, yeah. We've seen this. In any cohort, you're going to have one or two people that just do really well. There are a number of people who, in non-small cell cancer, lung cancer, blow through the chemoimmunotherapy. And then for some reason, they are really long responders on docetaxel.
Yeah.
That happens. So you're going to have these ones, but something that's a bit more applicable is the goal. Let's take it back a little bit because my study is going to actually look at the first line therapy. And in the context of Delphi, which, as you say, is probably the most exciting thing that's happened in the small cell space for a long time, certainly since atezolizumab. The study that I'm going to talk about, IMforte, potentially gives a bit of a preview as to how tarlatamab might be integrated into the existing first-line therapy. IMforte is a study that looks at the maintenance phase of first-line therapy for extensive stage small cell lung cancer. So we know that based on the Empower 133 trial, which is the atezolizumab trial, you have the 4 rounds of chemotherapy with carboplatin plus etoposide and then maintenance atezolizumab. So the focus of IMforte is that maintenance phase with the immunotherapy. Now, a couple of things about Empower 133. The initial response rates were between 50 and 70%, so a lot of people had a really good response. However, the benefit of the addition of atezolizumab to median overall survival, as Josh mentioned, is less than 3 months. It was about 10.3 compared to 12.9 months. The 5-year survival, Josh said 5%. There was a phase 4 Umbrella trial, which was sort of a post-release follow-up rollover trial, found the 5-year survival was 12%. So very, very similarly bad outcomes. So what IMforte did with this maintenance phase is added lurbinectedin, which we've established is a approved second-line therapy. It is a synthetic alkylating agent that is a current treatment option for second-line therapy. And there's a bit of, I guess, limited data on that, though. So there was a phase 2 basket trial that demonstrated encouraging clinical activity. There was the phase 3 Atlantis trial, which did not demonstrate any benefit of lurbinectedin plus doxorubicin compared to a chemotherapy control. And there's a confirmatory trial going on at the moment, which we won't focus on. So IMforte is a randomized open-label phase 3 study that basically added lurbinectedin to atezolizumab. 483 people were randomized, and we don't normally do this, but I do want to talk about the progression of patients who are enrolled. It's very grim reading. It's a whittling down of an initial 653 patients. So 653 patients were assessed as eligible. They had confirmed extensive stage disease, had good performance status, no previous treatment, and they commenced induction therapy. 82 patients discontinued treatment early. There were 36 deaths and 10 patients progressed in that first 4 cycles. And a further 88 were not randomized because after those 4 cycles, 56 patients had progressed and 12 had severe adverse events. So there's significant attrition even before you get into this maintenance phase. 483 patients did make it though, and they were randomly assigned 1-to-1 to receive atezolizumab plus lurbinectedin or atezolizumab alone. Now, this was an open label study, which, I don't want to criticize someone for logistics, but it seems like it could be fairly straightforward to have a matching placebo because the lurbinectedin is given at the same time period as the atezolizumab. Co-primary endpoints were PFS and overall survival, with the secondary endpoints being confirmed overall response and duration of response and safety. The 2 groups were well balanced with the exception of age. So significantly more people were older than 65 years in the control group, 63 compared to 51%, with a corresponding decrease in the number of people who are younger than that. Let's jump straight to the results. So in terms of progression-free survival, the combination arm, lurbinectedin plus atezolizumab, 5.4, atezolizumab alone, 2.1 months. Overall survival, combination arm, 13.2 months compared to 10.6 months. Both of these had a positive hazard ratio, 0.54 and 0.73 respectively, and both were statistically significant. The benefit was present across most significant subgroups, with the exceptions for overall survival being those with an LDH of greater than an upper limit of normal, which probably portends a higher burden of disease, and those who had received previous PCI, which is interesting. I'm not sure how that correlates, but yeah, probably unlikely to be directly related to the disease. Duration of response was 9 compared to 5.6 months, and fewer patients in the experimental arm received subsequent chemotherapy. 9% of patients in the control arm received subsequent lurbinectedin, which I thought was interesting that it was that low, only 9%. In terms of safety, as you would expect, there were higher rates of treatment-related adverse events and grade 3 or higher treatment-related adverse events in the experimental arm. There were double the rate of events leading to discontinuation, albeit 6% compared to 3%, so small numbers. And the additional toxicity was predominantly hematological. There were also higher rates of severe respiratory infection in the combination arm as well, which leads to the 5% of grade 5 adverse events in the combination arm, which is obviously significant. Now, 4 of those cardiopulmonary arrests, probably not a lot you can do. But there was a pattern, and see if you can pick it, because the grade 5 events of special interest, there was one of each of these: febrile neutropenia, sepsis, septic shock, COVID-19 pneumonia, viral pneumonia, and vascular device infection. What do they all have in common? They're all infective, and that is not going to be helped by a drug that causes hematological toxicity. So that is something to keep an eye on. It's also worth remembering that people with extensive stage small cell lung cancer almost by definition are going to be debilitated. And so their ability to fight infection at a baseline is going to be impaired. So yes, the combination is numerically better IMforte compared to atezolizumab alone. But looking at the numbers, and this might have been the same for you, Josh, it twigs something in my memory, because let's do the thing that we never supposed to do and compare this study with the IMpower 133, the original study for atezolizumab, because it is interesting how similar the results in the combination arm here compared to the atezolizumab alone arm in that study. So the median overall survival for maintenance atezo and IMpower 133, 12.3 months, 13.2 months here. In the combination arm, I should say. PFS, 5.3 months in the atezo arm, 5.4 months in the combination arm here. The control median overall survival, so remember that was placebo in IMpower 133, 10.3 months, and the PFS was 4.3 months. In this study, the atezo arm, atezo alone, overall survival 10.6 months and the PFS 2.1 months. And this begs the question, why? I mean, cross-trial comparison, blah, 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 blah. But the similarity of these numbers is striking to me. And is that a fact that the control arm in this study is underperforming and there's actually not that much benefit of lurbinectedin? Or was the original trial with atezo overperforming and there's actually not much benefit with atezo alone? And speaking to people who treat a lot of lung cancer, we do it on the basis of IMpower 133. And none of these dirty cross-trial comparisons should change that. But there's always been a little bit of skepticism, I guess, of exactly how much benefit atezo was having on average. You're going to get those people that respond really well. But yeah, I thought that was very interesting.
That is probably one of the most interesting points of this study is the comparison. I know that's a terrible thing to say, but you have to always ask when the control arms are different. It means they probably haven't had the right cohort to kind of sit in a room and have that standard treatment.
Yeah, and there will be factors, of course, and a lot of those we wouldn't be able to tell. When you're trying to make these dirty comparisons, you don't often see the numbers align to this degree. Another question, there was no data in the study on patterns of relapse, and I was wondering is the CNS a more prominent sanctuary site, because are we just sort of kicking the can down the road and more people are presenting with brain mets? The long and the short of it with IMforte, though, it's a potential treatment option for fit patients with untreated extensive stage small cell. But coming back to my original point, just before we close, Josh, this might be a pattern that a future Delphi trial follows, where instead of lurbinectedin, you have tarlatamab, and see if there's a synchronous effect there. A couple of very interesting studies, Josh.
It's actually a great one. It's a great conversation starter, knowing that trials are not always the gold standard. You might have to wait time to actually see outcomes.
And they're often opaque. That concludes our mini-series on extensive stage small cell. We hope you've enjoyed it, because we're going to be moving on. There is no breaks on the back to basics train. We're staying in the thorax though, because we're going to be talking about mesothelioma. And some people might say, oh, we'll just go back and listen to, what was it, episode 3, Josh? I think it was episode 3, one of our very first ones that we did. We've actually gone to the effort of finding a different study. So don't worry, it's not a complete rehash of an original episode. We both sound much better now, I think, after a couple of years of doing this nonsense.
180 odd episodes later.
So if you want to hear how much better we sound after 180 episodes, then tune in next week.
Cross-trial comparison right there.
Exactly. The dirtiest of all cross-trial comparisons. We'll see you next week.
Bye.
Thank you for listening to this episode of Oncology for the Inquisitive Mind, produced by ADC Productions, with the assistance of education grants from Pfizer, Gilead Pharmaceuticals, and Merck Pharmaceuticals. As always, these companies do not receive early previews or editorial input of any kind. The opinions expressed in this episode are our own, and the facts are, well, the facts. If you liked this episode, please consider subscribing to be among the first to hear our latest forays into the ever-changing world of medical oncology. You can find previous episodes of our show, including coverage of major conferences, interviews with world-renowned experts, and much more at inquisitiveonc.com. If you would like a particular subject covered on the show, drop us a line at inquisitiveonc@gmail.com. And if you happen to be in Australia, stay tuned for details about exciting in-person events we have planned for the near future. Thanks for listening, and we look forward to demystifying oncology again next time.